Hi everyone, we're going to talk about Chapter 43, Musculoskeletal Disorders. I'm going to ask you to review the pathophysiology in your book, but let's talk about the anatomy and physiology quickly. Just some things to know that the bone age of your child can be determined by taking an x-ray of the left hand and the left wrist, and it helps to measure growth tempos if there's concerns that the child is not achieving these, or if you're wanting to find out if the child has quit growing. Skeletal growth spurts occur for girls typically around Tanner stage 2 and for boys Tanner stage 3. And be sure and review the diagram of the long bone that's noted on page 886, figure 43.1. We know that long bones have growth plates called epiphyses, and blood flows through the epiphysis, and if there's been any damage or injury to the epiphysis, it can cause delays or stop in bone growth. And we all know that essential nutrients are needed to help with bone development: protein, calcium, and vitamin D. One part of the patho that I did want us to go over were the Salter-Harris classification of fractures. That is found on page 888 in figure 43.2. They're divided into 5 different fractures, where fracture 1 is a fracture of the epiphysis but no surrounding bone, up to fracture 5, which is a compression or crushing injury of the epiphysis. So be sure and look at that diagram, because it gives a really good visual of what the fractures will look like. And that was for growth plate fractures. Other fractures include shaft fractures, and these are dependent on the mechanism of injury. They're usually the result of tripping while walking or running, or stepping on something, or falling from a taller height. As with all of our patients, it's important to get a good history. When did the symptoms or the injury occur? Pain, where is it located? The type of effect it is having on activities. How is the child characterizing it? Is there any deformities, any altered gait? Does the parent have any musculoskeletal past medical history? For the child, were there any issues during pregnancy? Any issues with development, any recent injuries, illnesses, or surgeries? And then, of course, do a review of systems to assess for congenital problems, any diseases or infections. We want to look at the extremity, and you're looking for skin color. You're wanting to assure that it's getting good blood flow. You want to note that if there is any swelling, if there's any atrophy, redness, bruising, scars, pigmentation changes. You want to note how the child is sitting and standing and walking. You want to be evaluating one side versus the other side. Check for range of motion, their strength, their tone. It's important to check for reflexes and complete range of motion exercises, and assess for any hypermobility during your exam. It's always important to see how the patient is walking. Where are they on their developmental steps? You want to watch them walking with and without shoes, away from you and towards you. It's important to compare stance and how their arms swing, range of motion of each of the joints. You want it to be smooth and rhythmic. Limping would be considered a disturbance in gait. And know that disturbances can be more obvious when the child is tired. When you're checking for posture, you want to assess that the pelvis and the hips are level, that the legs are symmetric in shape and size, that feet are pointed straight, that the spine is straight, the back should look symmetric, and the shoulders, scapula, their height should be equal, and the waist angle should be equal. Next, we're going to talk about some different examinations that can be done for the musculoskeletal system. We are not going to go into detail of how each of these tests are done, but rather what area they assess. Hopefully in clinicals you've been able to use some of these, and if there are some that you have questions about, you can look at the diagrams in the book, but I think what would be a great asset is even just going to YouTube and Googling how to do these maneuvers, and likely they will have it there in just a minute or two video, and seeing a better hands-on may lock that into your mind. When we're talking about hip exams, the first one we're going to talk about is the Gillespie maneuver, and it is to look for conditions that may cause leg length disparities. So you're wanting to look with those hips flexed and the knees bent and look at that height. And that can be found on figure 43.3a. The next is the Barlow maneuver, and that's looking for dislocation of hips. And this is usually done within the first month or so of life, and it's looking for laxity and instability of the muscles. And the next is the Ortolani maneuver. It's the opposite or the reverse of the Barlow maneuver. It reduces the hip posteriorly. A click as the hip moves is not considered a positive Ortolani sign. And both the Ortolani and the Barlow can only be achieved during the first few months of life. So review those on figure 43.4 and 43.5. The Klissick sign is an observational sign that helps to determine if the hips are in proper placement. The Trendelenburg sign helps to identify causes that are causing weakness in the hip abductor muscles. And you're going to want to be checking for medial and lateral rotations of the hip. And if something is asymmetric, then that would be considered abnormal. To check for the back, you're going to want to perform the Adams forward bend position, and that's looking for asymmetry in the posterior chest wall, and we're evaluating for scoliosis, structural scoliosis at that time. Diagnostic studies can play an impact in the care that you're giving for musculoskeletal issues. Plain x-rays, AP and lateral views are very common, and often, not often, they will compare both extremities to note for any differences. CTs are more detailed, and especially in soft tissue concerns, and it's assessing for the relationship to the bone to the other structures. MRIs are used for joints, soft tissue, cartilage, and medullary bone, and then ultrasounds for cartilage tissues and effusions in the hip. Other diagnostic studies include bone scans, and they're more sensitive than x-rays, but we have to be aware of radiation levels with these exams. Other labs, including if you're wanting to assess for any systemic diseases, infection, inflammation, might include blood culture, CBC, SED rates, rheumatoid panels, ANAs, muscle metabolism such as lactic acids, and may even need to do biopsies of bone or muscle. So in our management strategies, there's lots of counseling that will be done, but that is based on the specific condition. But one thing is important when you are providing your well child visits, or something comes up that it may not be as raising a red flag, is providing anticipatory guidance regarding the musculoskeletal development of the child. It's important that parents are aware of what timelines and markers are, such as, infants and toddlers can have bowed legs and knocked knees, and preschoolers, and how those will develop and they will grow out. But being aware that parents know what to look for. Another management strategy is shoes. That is often controversial, as they do little to correct deformities, but the most important goal of shoes is to protect feet from injuries. Shoes should be flexible and allow motion, flat, shape to the foot, no pointed toes, fitted generously so there's a room for the child's foot to move around, and not to have friction points. Care of children in cast, the part of the body that has been injured is going to be immobilized to promote healing and stay in proper alignment. You can have splints that do not go all the way around the extremity, and they're used to accommodate swelling. Then there's casts that are circumferential that go all the way around. They're less forgiving, but it's important to keep them cool, clean, and dry. And teach your patient and their parents about circulatory assessment and nerve function assessment. We also have PT and OT for other conditions such as developmental delays, CP, spinal disorders, um, when the neck can twist, torticollis, and treatments to focus on improving gross versus fine motor balance, coordination, strength, and cognitive skills. Next, let's talk about some specific problems associated to children. Let's next talk about annular ligament displacement, and it's previously described as subluxation of the radial head and frequently called the nursemaid's elbow, and it's an injury that's common between 6 months and 5 years. And it occurs when traction is applied to the arm of the young child, which is most often the result of pulling the child by the hand or grasping the child's hand to prevent a fall or lifting up by the arms. Typically, there's immediate pain with limited supination. They don't want to flex or extend their elbow on x-ray. It's usually normal. You can attempt to reduce. If this is not effective, then you need to consider that a fracture. We're not going to go into detail for techniques to reduce. There's more information about that in the book. I think that's definitely one that needs to be performed with a mentor or watching a video. But it's important to, talk to the child in a non-threatening manner and explain what's going on. And if you do attempt this, an audible pop or click usually means that there's been a reduction, and typically the child is then able to start reaching for things, and there's no pain. If there's no reduction, it's important to immobilize and refer to urgent care, ER, or orthopedics, and recurrences may occur. Next, let's talk about the brachial plexus injuries, and these occur within the shoulder. There's 4 different types based on the nerves and the muscles that are involved. We also have 3 different types of ones that we're going to talk here. The Herb Duchenne palsy is a weakness or paralysis of the shoulder or upper arm. The Dejerine-Klumpke palsy is hand. Ipsilateral ptosis or meiosis. And I believe this is similar to the Horner syndrome, where we have impact if the fibers of the T1 nerve root are involved. Newborns can have issues if there's been a tight pelvis that they have come out of. So that's why it's important to always obtain your obstetrical history for children if you're concerned about issues of nerves in the shoulder, how they were delivered, what their postnatal health was. You're going to want to perform a physical exam and note the location of their arm, their biceps, their wrist. You want to assess that they have good neck movement. Could there be any skull fracture? Is there any impact on the respiratory system? Radiologically, you're going to consider electrophysiological studies. An MRI may be useful to help with the clinical diagnosis or the extent. Chest x-ray is important to rule out if there's any phrenic nerve injury, as the phrenic nerve we know controls the diaphragm. This is a multidisciplinary team case. Referrals are typically made within the first weeks of life. There can be some complications with internal rotation contractures or hyperplasia of the arms, and recovery may occur spontaneously, but more severe issues may require surgery in future years. Next, let's talk about clavicle fractures, and this happens in newborns from a birth trauma, typically accidental or a non-accidental trauma. Important to get a good history. On your physical exam, you're wanting to see if there's pain with shoulder movement, decreased arm movement, if there's asymmetrical arm movement, swelling, crepitus, spasms. Radiological imaging will help in the determination of the fracture. In babies, no treatment or immobilization is needed. You can just pin the infant's shirt sleeve to their the sleeve to the body of the shirt. With children, sling immobilization for comfort, a figure 8 brace, and some analgesia. Prognosis is good. Next, we're going to talk about costochondritis and sternochondritis, and it's one of the most common causes of chest pain in children and adults. It's inflammation of where the costochondral cartilages join the sternum. Trauma, heavy lifting, coughing are causes. Most patients may complain of a localized pain at the costosternal or the costochondral junction. It can be acute or gradual, sharp or dull, and it may radiate. They can have reports of muscle spasm, tightness in the chest. On physical exam, you may notice tenderness where the ribs join the sternum, and there can even be the Tietz syndrome, which is pain or swelling or redness in that area. No diagnostic studies are needed. You need to take into consideration there could be rib fracture as a differential diagnosis. Management includes minor analgesia with NSAIDs or Tylenol and cough suppressants if cough has been part of the equation. Next, let's talk about back pain, and these are episodes with nonspecific findings, more common in children greater than 4 years old. They may have persistent symptoms, limited activity, nighttime pain. There may be systemic or neurological symptoms. Important to get a good history, when it started, how long, the location, intensity. With older children, it's important to assess if they've been participating in sports, wear high heels, sitting at the computer. On our physical exam, you're going to want to do a complete musculoskeletal and neurological exam. You're going to want to try to rule out if there's any infections, any rheumatoid issues. You'll be doing AP and lateral x-rays. You may need to do MRIs or CTs if there's neurological symptoms or bone involvement. Your differential diagnosis would include occult pathological conditions. There could be discitis, osteomyelitis, fractures, or tumors. Management is going to be determined by the cause, and then the goal is pain management and physical therapy to help get this child back to normal activity. Next, we're going to talk about scoliosis, and it's a three-dimensional deformity of the spine. The lateral curve of the spine in the frontal plane. There are different ones. Non-structural, which is functional. It's a curve without rotation of the vertebra, most often reversible, caused by posture, pain, or leg length discrepancy. And then there's the structural, which is the rotational element of the spine. Diagnosis is made for a curve greater than 10 degrees using the Cobb method. It's further broken down to idiopathic, which is the most common cause, congenital, which is a structure anomaly at birth, and then neuromuscular in non-ambulatory children. It's important to check your family history for scoliosis, age of menarche. On physical exam, you're going to want to evaluate a standing position from the front and the side to look for asymmetry. You're looking for shoulder height, scapula prominences, the waist angles, rib prominences, elbow to flank distance. You're wanting to check all of those balances. You're also wanting to check for any hairy patches, nevi, cafe au lait signs, or dimples. Diagnostic studies are going to include AP and lateral. You need to consider structural versus functional issues or any systemic problems in your differential diagnosis. And the management is going to be to stop the curve progression, and if there's been any pulmonary function, to help improve that. Care may include observation, bracing, or surgery. Referral is essential. Next, let's talk about kyphosis while we're still talking about backs, and that's an exaggerated curvature of the thoracic spine. It is most common. On x-ray, you may see that there is a narrowing disc space or a loss of normal anterior height or vertebral space. Management includes exercise and physical therapy, dancing, swimming, anything to be more active, and those can all be helpful. And if structural, refer to an orthopedic surgeon for observation, which may include bracing or surgery. Our last back issue is lumbar lordosis, which is a curvature of the lumbar spine. Um, Congenital lordosis is usually progressive and it may be secondary to a hip problem. It's important with these children to determine whether it's a physiological issue. If the lumbar spine flattens and the lordosis disappears when the child bends forward, then it is considered a physiological condition and no treatment is needed. If it's more fixed, then referral to orthopedist is needed. We are about halfway through with these slides, and this is a good break before we go into hip issues. So we will pause here and come back for developmental dysplasia of the hip.